I'm very pleased to be providing this March 2024 update on COVID therapeutics. These are my disclosures. Before getting into the new data, I want to place things in context because it's becoming much more challenging to do drug development for the treatment of acute COVID-19. A number of factors play into these challenges, and they include the fluctuating incidence and location of COVID-19. It's hard to know when and where to initiate trials to demonstrate the efficacy of novel therapeutics. There are also high levels of pre-existing immunity. That's great for the population at large. It makes it much more challenging to develop drugs because there are much lower rates of progression to severe disease, and most of the drugs that we have approved so far were approved on the basis of preventing progression to hospitalization or death. There are also regulatory requirements that have insisted on placebo-controlled trials because the alternative would be non-inferiority trials, and there's just not enough confidence in the efficacy and the magnitude of benefit from existing therapies that a non-inferiority trial is deemed appropriate. Because it's unethical to take people who are at high risk of developing severe disease and place them in a placebo-controlled trial. That makes it even more challenging to show efficacy because now you're taking low-risk people and randomizing them, and there will be many fewer endpoints as a result. Lastly, there's been uncertain acceptability of time to symptom resolution as opposed to reductions in progression to hospitalization or death as an approvable endpoint. That's particularly true with the Food and Drug Administration here in the United States. And you'll see some of the trials I'm going to discuss today, speeding the time to symptom resolution, which is an endpoint actually that's been used in the past for drugs for respiratory viral infections, particularly for oseltamivir and baloxavir that are used to treat influenza. Well, let's start with a quick update from some news that was presented at CROI, the Conference on Retroviruses and Opportunistic Infections, held the first week of March in Denver, Colorado. This is a study done by my colleague, Jonathan Lee, presented by one of his laboratory personnel on the emergence of minority-resistant variants in patients receiving nirmatrelvir or remdesivir for the treatment of COVID-19. They had about 80 people on nirmatrelvir or ritonavir and just under 15 on remdesivir, and they self-collected nasal swabs on a routine basis during the course of their illness. These were all outpatients. These swabs were then submitted for sequence analysis by next-generation sequencing. What they showed, focusing first on those who received nirmatrelvir ritonavir, was that the emergence of minor variants that encoded for nirmatrelvir resistance was more common in the nirmatrelvir ritonavir treated group. You can see that was 11% compared to 3%. That difference was not terribly different among those who did or did not have virologic rebound, but there was a big difference in those who were receiving immunosuppressive therapy compared to those who weren't. This slide is a little bit confusing, but I'll explain it. Every single horizontal row represents a different participant, and the vertical columns represent different mutations. And then there's a color scheme based on this heat map. So blue indicates a very low frequency for a variant, and red indicates a high frequency. And what you can see in this sort of scatter plot here is that different participants in this study had different mutations arising, but almost all of them arising at very low levels. Those indicated by the vertical green lines are mutations at positions previously shown from in vitro work to be associated with reduced susceptibility to nirmatrelvir. Now, what you can take away from this slide is that although there were a lot of mutations that emerged, they all emerged at very low levels. None of these mutations appear to be responsible for treatment failure because in no case was the majority of the virus resistant to nirmatrelvir by genotype. Very similar findings were seen with remdesivir. Again, a variety of mutations. In this case, a couple of mutations were seen at relatively high frequency, as indicated by the red color, but those were not at positions associated with resistance to remdesivir. So the takeaway from this study is that emergent nirmatrelvir resistance mutations were detected more frequently in those receiving nirmatrelvir ritonavir compared to untreated participants. But among those who received the drug, emergence of nirmatrelvir resistance was highest in the immunosuppressed group. Emergent remdesivir resistance mutations were also detected in 2 immunosuppressed participants. But as I mentioned, the emergence of resistance was present at very low frequencies, appeared only transiently, and was unlikely to be a substantial contributor to virologic rebound. These results suggest that the risk of widespread dissemination of significant antiviral resistance in COVID-19 remains low, which is really very reassuring. Another update from CROI is this poster that analyzed retrospectively data from a very large cohort study comparing the use of dexamethasone alone versus dexamethasone plus remdesivir. Remember that dexamethasone has been shown to be life-saving in people hospitalized with COVID-19 where there's at least moderate hypoxia. There's been some question about the extent to which remdesivir actually improves survival. This study was based on hospitalized people with COVID-19. The primary endpoints were 14 and 28-day all-cause inpatient mortality. The analyses were performed 2 different ways. Because this was a cohort study, of course, it's not randomized and you worry about imbalances in patient characteristics. And so they tried to match the participants, those who did and didn't get remdesivir, by propensity score matching and also by using inverse probability of treatment matching. After applying the inclusion and exclusion criteria, there were over 150,000 patients hospitalized for COVID-19 who were included in the analysis. More than 61,000 had initiated remdesivir and dexamethasone in the first 2 days of hospitalization, and more than 36,000 had initiated dexamethasone monotherapy, also within the first 2 days of being hospitalized for COVID. We look at these forest plots. What you can see is whether they used propensity score matching or inverse probability of treatment weighting, that the outcomes strongly favored the combination of remdesivir and dexamethasone. And here the stratification is on the basis of the level of requirement for supplemental oxygen. So NSO is no supplemental oxygen, then there's low flow oxygen, high flow or non-invasive ventilation, and then invasive mechanical ventilation or extracorporeal membrane oxygenation. And you can see whether you're looking at 14 or 28-day mortality by either of the matching schemes, there is about a 20 to almost 30% reduction in mortality, all of which were highly statistically significant, depending again on the extent of supplemental oxygen that was required. Turning now to some novel studies of agents for outpatients with COVID-19. There are several new drugs, 2 protease inhibitors and 1 polymerase inhibitor that I'll talk about. Interestingly, each of these studies has been done in China. The first of these is a study of oral simnotrilvir for adult patients with mild to moderate COVID-19. Simnotrilvir is an orally bioavailable SARS 3CL protease inhibitor. It's a protease inhibitor that is the same one as inhibited by nirmatrelvir and encetrelvir, which we've discussed in the past. This was a phase 2b/3 randomized double-blind placebo-controlled trial. Participants had mild or moderate COVID-19 and were within 3 days of symptom onset. They were randomized equally to receive simnotrilvir at 750 milligrams daily plus ritonavir. This protease inhibitor also requires boosting, as does nirmatrelvir. I'm sorry, they received this twice daily, or placebo for a 5-day period. And the primary endpoint was time to sustained resolution of symptoms, defined as the absence of 11 COVID-19 related symptoms for at least 2 consecutive days. This slide shows the results. There were more than 1,200 participants enrolled at 35 sites in China. All of the cases were due to Omicron, and you can see here that about a quarter of them were from BA 5.2 and 40% were BA 5.2.48. Then there were a smattering of other Omicron-related variants. Interestingly, more than 3/4 of the participants had been vaccinated and had received booster vaccines. What you can see in the slide, in the panel here at the bottom left, where the orange color is the experimental group receiving simnetrovir plus ritonavir, and the blue are those who received placebo, that the time to symptom resolution was faster in the treated participants compared to those who got placebo. And if we look at the median time to resolution, you can see that that was 180 hours in the simnetrovir ritonavir group and 216 hours in the placebo group. That difference of just under 36 hours, or about a day and a half, was highly statistically significant, as you can see by the confidence limits, which both of which fall below zero. In terms of adverse events, there were slightly more adverse events in the simnetrovir ritonavir group. You can see overall nearly 30% versus about 22%. But there were very few grade 3 events, no grade 4 or 5 events, and very few participants discontinued therapy because of an adverse event. Loretrovir is another protease inhibitor. It also inhibits the 3CL protease, but this protease inhibitor does not require ritonavir boosting, and it too is orally bioavailable. This study was a phase 3 randomized double-blind placebo-controlled trial in participants who, like the previous study, had mild or moderate COVID-19, were within 5 days of a positive nucleic acid test for SARS-CoV-2 and had to have symptoms present within the 2 days prior to entry so that they could track the resolution of those symptoms. They were randomized, again, 1-to-1, in this case to loretrovir, which was given as 400 milligrams 3 times a day, or placebo for 5 days. There's no ritonavir requirement here. The primary efficacy endpoint, once again, was time from the first dose to sustained clinical recovery of all symptoms. And the study enrolled just under 1,400 participants at 29 sites in China. This slide shows the results analyzed either by intention to treat on the left or in a per protocol analysis on the right. Here the Kaplan-Meier curves are flipped upside down compared to the previous study. But once again, what you can see is the intervention group shown in red, where the drug is being named by its previous designation, RAY 1216, instead of loretrovir. But the treated group had a faster time to resolution of symptoms compared to the placebo group. There was about a 20% greater likelihood of improving in terms of the hazard ratio, which was statistically significant, as you can see, and the same was true when analyzed as a per protocol analysis. We look at time to sustained recovery. The loretrovir group recovered in about 250 hours, in the placebo group about 270 hours. So again, about a 1-day difference. And to place that in context, that's really similar to what we see with oseltamivir and baloxavir for resolution of symptoms in people with influenza. And that was a statistically significant difference. Looking at the safety profile, adverse events, again, were slightly more common in the loretrovir group than in the placebo group, but really these numbers are pretty much the same. And if we look at adverse events considered to be related to the assigned regimen, that was 32% in the loretrovir group and 28% in the placebo group. VV116 is a form of remdesivir. Its official name is now mendudesivir, I should say, and it is a deuterated remdesivir hydrobromide, so that's a mouthful. But it is a version of remdesivir that is orally bioavailable. Remember, remdesivir is given intravenously. So this was a phase 3 randomized double-blind placebo-controlled trial in patients with mild to moderate COVID-19, same kinds of patients as in the other two trials. Eligible participants had symptom onset within 3 days of entry, and they were randomized equally to receive VV116. There was an initial loading dose, 0.6 grams twice a day for the first day, and then 0.3 grams twice a day for days 2 through 5, or they received placebo. The primary endpoint was time to resolution of symptoms for at least 2 consecutive days, and there were just under 1,370 participants randomized at 31 sites across China. This slide shows the results, and here the color pattern has changed. So blue is now the treated group and red is the placebo group, but otherwise the same kind of graph as the same kind of Kaplan-Meier plot as what I showed you for the previous trial, where the treated group here has a faster time to symptom resolution compared to the control group. Even though time to 2 days of symptom resolution was the primary endpoint, they also looked at time to 3 days of symptom resolution, and they found essentially similar results. Looking at the actual data numerically, what you can see is that the median time to resolution here in terms of days was just under 11 days for the treated group and just under 13 days for the placebo group for 2 days of resolution and 12 and 14 days respectively if we're looking at 3 days worth of symptom resolution. And then turning to adverse events, there were really in this case, actually fewer treatment emergent adverse events in the treated group, about 36% compared to 42% in the placebo group. Likewise, fewer drug-related adverse events than in the placebo group. These are as ascribed by the investigator. And if we look at, there were no serious treatment emergent events in the VV116 group. And there was only a single treatment emergent adverse event that led to study drug discontinuation in either arm. Finally, turning to the latest study from the REMAP CAP group, which has done these amazing series of platform trials. This is a study of simvastatin in critically ill patients with COVID-19. Now, statins are known to have anti-inflammatory effects, and of course, in the HIV world, we've just seen the impact of statins on cardiovascular disease in people with HIV, even among those with low-ish cholesterol levels. And meta-analyses of observational studies have suggested improved outcomes in patients with COVID-19 who were receiving a statin at the time that they became ill with SARS-CoV-2 infection. So this was an international randomized controlled adaptive platform trial in which just under 2,700 participants who were critically ill with COVID-19 and not already receiving a statin were randomized to receive simvastatin at 80 milligrams daily or control. And the primary endpoint was in-hospital death and days of free of organ support through day 21. Now, organ support would mean need for invasive ventilation or dialysis or pressors and the like. This study, like others we've discussed in the past, used Bayesian statistics. And so the analysis was performed using a Bayesian hierarchical ordinal model with a pre-specified criterion for superiority requiring the probability that the odds ratio was greater than 1, meaning of favoring the use of simvastatin had to be 99% or greater. So remember, when we think about standard p-values, we're looking at very small numbers to be statistically significant, and in Bayesian statistics, where we look at the posterior probability, we want to be very certain that the difference is real, and therefore a very high probability. In this case, unfortunately, the study enrollment was halted due to declining enrollment as SARS-CoV-2 infection tailed off in incidence. Nevertheless, the investigators were able to conduct a fairly well-powered analysis And just to orient you to these slides here, now this is not a typical Kaplan-Meier plot. What we're looking at is the proportion of the cumulative proportion of participants who have different numbers of days of organ support. So obviously, if you died, then you have less than 0 days of organ-free support. If you were intubated the entire time, then over the course of 21 days, you had no organ support-free days. But if you never required organ support, then you had 21 days. And you add up all the participants over the entire course, so you always reach 100%. And what you can see is that there's a little bit of shift to the right favoring the simvastatin group, but it's not a very large difference. And if you look here at the ordinal endpoints where the numbers of days of organ-free support is plotted for the proportion of patients, so essentially a very small segment of the population were free of organ support for 21 days, and then about 30% or so had very few days during which they were free of organ support. You can see that, again, the distribution slightly favors simvastatin over control, but it doesn't appear very large. And if we look at the actual statistics, what we see is that the median number of organ support-free days for the Simva group was 11, and it was 7 for the control group, but the posterior probability of superiority was only about 96%, and that fails to reach the 99% threshold that was pre-specified as indicating a positive result. If we look at in-hospital survival, we can see that the odds are even less favorable. First of all, the adjusted odds ratio of survival was about equal, and there was only about a 64% chance that the simvastatin group was going to come out ahead, and that's well below the 99% threshold that was established. Conversely, if we look at adverse events, about 3% in the simvastatin group and 2% in the control group had serious adverse events, and that actually did achieve a probability that simvastatin may have been inferior. So to sum up, really no evidence that adding a statin, at least simvastatin, provides any clinical benefit to people who are hospitalized with critical COVID-19. So I hope you found these results interesting, and I look forward to our discussion.